Dear Chairman, ladies and gentlemen, it's a great honor and pleasure for me to be here. In contrast to moderate myopia, high myopia is a major risk factor for the development and amount of optic nerve damage, in particular glaucomatous optic nerve damage. With a prevalence of about 80% in extremely myopic patients in this hospital-based study. Marked anatomical changes in the optic nerve in myopia may be associated with this increased prevalence. It includes a lengthening and thinning of the lamina cribrosa in highly myopic eyes, in association with a secondary macrodisc in highly myopic eyes, so that the lamina can become as thin as just 50 micrometers in myopic eyes. It may have marked importance for the biomechanics of the lamina, as well as for the translaminar cribrosa pressure difference and gradient. In the parapapillary region, several zones can be differentiated. First, an alpha and beta zone, as also in non-highly myopic eyes, with alpha zone defined by the presence of Bruch's membrane and presence of irregular RPE, and beta zone shown here with the presence of Bruch and absence of RPE. And this beta zone in glaucomatous eyes may perhaps be associated with changes in the IOP, with an IOP increase leading to a piling up of the RPE end, in association with a slight enlargement of beta zone during the high IOP phase, and with a regression of the piled up RPE end after normalization of IOP. And interestingly, histologically, one finds these drusen-like formations also in the parapapillary region, as well as in routinely taking OCT images. These parapapillary drusen in glaucomatous beta zone have similarities with RPE drusen in the macula in eyes with AMD. In contrast, eyes with myopic beta zone don't show these parapapillary RPE drusens, just a normal Bruch's membrane, as also shown in this example, suggesting that one may differentiate between a glaucomatous beta zone and a myopic beta zone. Myopic eyes additionally show gamma zone defined by the absence of Bruch's membrane, and when we see the development of gamma zone in this adolescent, moderately myopic patient, we see that gamma zone enlargement is associated with the shortening of the ophthalmoscopical visible part of the optic disc. In correspondence, OCT images show an overhanging of Bruch's membrane on the side without gamma zone, corresponding to the length of gamma zone on the other side of the optic disc. It led to the notion that axial elongation is associated with an enlargement of Bruch's membrane in the mid-periphery, leading to a shift or movement of Bruch's membrane opening in direction to the macula, as also suggested by this light microscopical image, or also by other OCT images, and shown in this diagram. Correspondingly, eyes with an inferior gamma zone have a superiorly overhanging Bruch's membrane, an inferior leg of Bruch's membrane, that's gamma zone, and an inferiorly located foveola. Also, in favor of the notion of a shift of Bruch's membrane is that the deep retinal layers overhang into gamma zone. In highly myopic eyes now, one has a circular gamma zone, which may be explained by enlargement of Bruch's membrane opening, so that gamma zone is present also on the nasal part. Then there is delta zone, based on the physiological appearance of the peripapillary scleral flange, which connects the sclera with the lamina cribrosa, and the flange can elongate by a factor of 10 and become thinned by 90%. And since the flange is the biomechanical anchor of the lamina cribrosa, it may be another risk factor for increased glaucoma prevalence. Gamma and delta zone can be seen also by simple ophthalmoscopy, and of course much better by OCT. Another anatomical risk factor potentially for the increased glaucoma prevalence in highly myopic eyes may be the increased distance between the peripapillary arterial circle and the lamina cribrosa, the distance being increased by the elongation of the scleral flange. Then, there's a peripapillary border tissue, which is the continuation of the pia mater of the optic nerve going over into the peripapillary border tissue of the scleral flange, continuing into the peripapillary border tissue of the choroid, finally connecting with the postmembrane end. The choroidal border tissue is the only connection between the inner ball of the eye and the sclera in the posterior part of the eye, so that there may also be a biomechanical importance. The border tissue also seen by simple OCT technology. And the border tissue is elongated in eyes with gamma zone, in particular in highly myopic eyes, which may be another reason for an increased glaucoma prevalence. If the border tissue ruptures, one may perhaps get this corrugation of postmembrane. Another factor is that extremely elongated eyes may face a situation that the optic nerve becomes too short to allow a marked adduction, leading to a backward pull of the optic nerve on the optic nerve head, leading to forces playing a role in the physiology of the optic nerve head, and perhaps also being the reason for the peripapillary suprachoroidal cavitations, as also shown in this example. All these factors may be associated with the marked increased prevalence of a glaucomatous or glaucoma-like optic neuropathy, and it's not yet clear whether it is indeed glaucomatous because there has been no study published yet which has shown the association between this glaucoma-like appearance of the optic disc with IOP. Risk factors were an enlarged optic disc and a large delta zone. Besides glaucoma, there's non-glaucomatous optic nerve damage. We know that for each millimeter elongation, the distance between the aura and the optic disc increases by 0.7 millimeters, leading to a lengthening and stretching of the nerve fibers, and the same holds valid for the macular fibers by the development of gamma zone, as one may also see here. And also patchy atrophies with an enlargement of postmembrane defects lead to a lengthening and stretching of the nerve fibers, and that may be the reason for the high prevalence of a non-glaucomatous optic nerve damage in highly myopic eyes, which may be the reason for central visual field defects, in association, of course, with an enlarged blind spot. How to detect glaucomatous defect? Here we may see a non-glaucomatous disc since the shape of the rim is preserved, as also here, but here we see the vessel kinking close to the disc border, typical for glaucoma. So that, as a rule of thumb, all highly myopic eyes should be considered to have an optic nerve damage until the contrary has been proven. Thank you very much.
Thank you very much for this very interesting and well-documented, but very pessimistic presentation. So, so what's your recommendation in practice? How do we translate this in a daily practice? So we say to patients that you have a damage, likely you have a damage?
Yeah, first, always check the optic disc, and in case of doubt, think there may be glaucoma. Second, one can tell the patient if the intraocular pressure is normal after correction of the central corneal thickness. There is no study showing the benefit of an IOP reduction, but one can try it. And if the patient tolerates the intraocular pressure lowering therapy, one should go for it until studies have been shown whether it's helpful or not. Large randomized trials are coming up in China, but they will need at least 2 or 3 years more to give some more information.
So what's your limit once corrected for the cornea of pressure in myopic eyes to begin a treatment, to propose a treatment?
From a personal point of view, if I think there's a glaucoma-like appearance, I will always like to lower the pressure independently of the outcome pressure. If it's 20, 15, or 12, to lower, if it's tolerated, is highly likely of no harm.
So finally, this glaucoma-like, distinction of the glaucoma-like is more important than the pressure.
Exactly.
That's the point. Is there any questions? Or? Yeah, so thank you very much. Thank you.
So it's my pleasure to announce the next speaker.